Now let me be clear right from the start. Watching this video won't suddenly turn you into a doctor. You won't be writing prescriptions or running MRI scans after this. But what I can do is give you a glimpse of what actually goes through a doctor's mind when we're faced with a patient who may be having a stroke. And trust me, those first few minutes matter because getting it wrong could mean life or death. This video has been specifically requested by my subscribers, so please do subscribe and comment below if you want more content like this. Before we go any further, a very important note. This video is for educational purposes only. If you or anyone you know develops symptoms that could be a stroke, please seek urgent medical attention immediately. Don't sit at home analyzing whether it's a stroke or migraine. Let us do the analyzing. So here's the problem. Strokes are one of the most time-sensitive conditions in medicine. But here's the challenge. Other conditions can mimic stroke. Migraine, seizures, even a trapped nerve in the neck can sometimes look suspicious. So how do doctors actually separate the real deal, a stroke, from everything else? Well, we have a mental checklist, and I want to share it with you today. There are 4 big principles I use in my own clinical practice. I've put timestamps for each one, so you can jump in between the sections as you like. In addition, to make it stick, I'll show you an example for each one. Let's dive in. The first principle is focal versus non-focal. When we talk about a symptom being focal, it means it's affecting a specific, localized function of the brain. Remember, different parts of your brain control different areas of the body. So, a stroke in the left brain might cause weakness in the right arm and leg. That's focal. If someone says, "Doctor, I feel generally tired all over," that's not focal. Fatigue, dizziness, feeling spaced out, these are non-focal, and that usually points away from stroke. Let me give you an example. A woman in her 50s comes to the ER saying she suddenly couldn't move her right arm, but her left side is fine. That's focal, very suspicious for stroke. Compare that to someone who says, "I feel dizzy, weak all over and just not quite right." That's non-focal, less likely to be stroke, more likely to be something like low blood pressure, infection, or anxiety. So rule number 1, strokes cause focal deficits. They pick on one side, one function, not the whole body all at once. This brings us to principle number 2, negative versus positive symptoms. This one is subtle but incredibly powerful. Stroke symptoms are usually negative, meaning the brain loses a function. You can't move your arm. You can't see on one side. You can't speak. Something is missing. In contrast, conditions like migraine or seizures are positive symptoms. They add something abnormal: tingling, flashing lights, zigzag patterns in vision, jerking movements. So when I'm listening to a patient, I'm always asking, is this a loss of function, or is the brain producing extra activity? Here's an example. A 30-year-old comes in saying, "I'm seeing flashing zigzags in my vision, and then I got a pounding headache." That's a migraine aura, positive symptoms. Now compare it to someone who says, "Doctor, my vision in the right half of both eyes suddenly went black. I can't see that side anymore." That's a stroke, negative symptom. It's one of the quickest mental shortcuts doctors use, and it's surprisingly reliable. Principle number 3 is sudden versus gradual onset. The next big clue is onset. Strokes usually happen suddenly. You can often pinpoint the exact moment. I was eating lunch and boom, my arm went numb. Migraines, on the other hand, often build up over minutes to hours. A nerve injury tends to evolve over days. So I'm always asking patients, did this come on instantly or did it creep up? Let me illustrate this. A man in his 60s is sitting at the breakfast table. He reaches for his coffee and his arm just drops, completely lifeless. That's sudden. Classic stroke story. Now picture someone who develops a headache, then 10 minutes later sees zigzags, then 20 minutes later feels their hand tingling. That gradual build-up screams migraine. Stroke tends to strike like lightning. Migraine builds like a storm. And finally, principle number 4, maximal at onset versus progressive. This is closely linked to onset, but slightly different. In stroke, the symptoms are maximal at the very start. You go from normal to completely weak in seconds. In contrast, mimics usually progress. A trapped nerve might start with tingling, then weakness over days. A migraine builds aura, then headache, then sometimes neurological symptoms. That sudden, all-at-once, maximal presentation is what makes stroke so distinctive. Imagine two cases. Case 1, a woman is typing an email and suddenly she can't move her left hand at all. From full strength to zero, instantly, that's a stroke. Case 2, a man says, "My hand felt a bit tingly yesterday, then weaker today, and now I can barely grip." That's progressive, much more like a nerve root compression in the neck. This difference, maximal at onset versus progressive, is often the deal breaker in our thinking. So what happens when someone arrives in the hospital with suspected stroke? We're running this mental framework in real time. Is it focal? Are symptoms negative? Was onset sudden? Were symptoms maximal at the start? If the answer to most of these is yes, it's very likely a stroke. But of course, we don't just stop there. We check risk factors: age, blood pressure, diabetes, atrial fibrillation. We do a neurological exam. And crucially, we get urgent brain imaging, a CT or MRI, to confirm and decide on treatment. The point is, these 4 principles are the mental shortcut that helps us get to the right tests quickly. Let me also address some common misconceptions that come up. Some people say, if it's a headache, it can't be a stroke. Not true. Headache can happen with some strokes, though it's not the classic presentation. Another myth: if the symptoms go away, it wasn't a stroke. Wrong. That could be a TIA, a transient ischemic attack, which is a warning sign of a much bigger stroke to come. And finally, if you're young, you can't have a stroke. Unfortunately, strokes can happen at any age, even in people in their 20s or 30s, though risk does increase with age. Let's recap the 4 big principles that help us tell stroke from mimics. Number 1, focal versus non-focal. Strokes pick on one side or one function. Number 2, negative versus positive. Strokes cause loss of function, not extra sensations. Number 3, sudden versus gradual. Strokes strike suddenly, not slowly. And number 4, maximal at onset versus progressive. Strokes are worst at the very start, not building over time. Remember, these aren't foolproof. Only a doctor with scans and assessment can make the final call. But understanding them can help you appreciate why we treat suspected strokes so urgently. So, no, this video hasn't turned you into a doctor, but hopefully it's given you a powerful insight into how doctors think when they see someone with suspected stroke. And if you take just one thing away, let it be this: if in doubt, always call emergency services. Don't second guess it, because when it comes to stroke, time is brain. Thanks for watching. If you found this helpful, drop a comment below with your questions. I'll be reading them, and who knows, your question might inspire my next video. And of course, subscribe if you want more evidence-based, life-saving health content. See you next time.